Environmental Health Center has a table set up on the side wall here, and they have information and services that they can provide for you should anyone have any needs for their services. So we ask that you take a minute today to visit their table and find out how they can help you. Please help yourself to a drink and a treat this morning, and there's a free will offering box in the back of the room if you care to place anything in it. It helps us offset the costs of this day. Chances are that everyone in this room has been touched in some way or is close to someone touched in some way by mental illness. 1 year ago at this time, we held a symposium on the disease of addiction in a post-COVID world, and today's symposium is closely related. Reports show that record high numbers of Americans are facing depression and suicidal thoughts. Nearly half of young people report feelings of persistent sadness and hopelessness. Today we're going to talk about what's behind this crisis and how the church can help. Please join me in welcoming Dr. Harry Dumais, President of the College of Our Lady of the Elms. Prior to his inauguration at Elms College in 2017, Dr. Dumais earned an MBA and graduate certificate in corporate finance from Boston University, a PhD in higher education administration from Boston College, and has served in various financial and administrative roles at St. Anselm's College, Harvard University, Boston College, and Boston University. Dr. Dumais has consulted internationally on projects related to international higher education and economic development with organizations in Europe and the Caribbean. He also serves as a board member, treasurer, and member of the Executive Committee for the Association of Colleges of St. Joseph Endicott College, the Western Massachusetts Economic Development Council, the Pope Francis Preparatory School, Build Health International, Health Equity International, and the Haiti Development Institute at the Boston Foundation. Please join me in welcoming to the microphone Dr. Harry Dumais.
Thank you, Celeste, for the introduction, and good morning, everyone.
Good morning.
It is my privilege to welcome you to our quiet campus because our students just went on spring break, except for the valiant students from Father's Mark Accelerated Nursing classes who are here today. But welcome to our second forum, Mental Health Challenges in a Post-COVID World, a Pastoral Response. And it is my distinct honor to welcome His Excellency Bishop William Byrne, a great friend and supporter of Elms College, who is with us this morning. Welcome, Bishop Byrne. Elms College is always pleased to welcome Bishop Byrne to our campus, so thank you for being here. We're most appreciative of the work and support the diocese has provided in partnering with Father Mark Stelzer and Dr. Michael McGravy of our Institute for Theology and Pastoral Studies. It is through that partnership that this program is possible. So before I go any further, I just want to say thank you to Celeste Labby, Father Mark Stelzer, and Professor McGravy, and everybody else who made this morning possible. Working together, they launched this program a year ago in response to a unique circumstance in American history, if not in the history of the modern world. We had just emerged from a global pandemic that caused millions of deaths, brought every aspect of our society and the economy to a halt, and forced people to retreat into isolation, away from the many social ties that bind us together. The end of the pandemic did not simply mean everything reset to the way it was before. It does feel that we all think that the way it is, right? But it didn't. there remain several very serious issues and challenges that we continue to face globally, nationally, and locally. This forum was created as a way to discuss what we in the area with the church can do to help our own. The focus of last year's forum was combating addiction. This year, the topic is mental health. There's no question that we are in a mental health crisis. Many people need assistance, but in many communities, available services are already stretched too thin. There's a shortage of skilled social workers, as we know very well here at Elms College. We prepare social workers. This forum and our guest speakers seek to provide the space for those in attendance to consider ways in which they can assist those in the community who need help. Catholic colleges and universities, the bishops of the United States frequently note, have an important role to play in promoting and advancing the mission of the church. Elms College sees a vital role in working together with and being at the service of the Springfield Diocese to aid our community amid the great challenges and uncertainties of the times before us. Father Mark Stelzer plays a critical role in guiding us in that regard, and we are thankful to him for that. I would also like to welcome and thank our two main guest speakers today, Dr. Ariel Laudermith of Veterans Affairs, Central Western Massachusetts Healthcare, and Dr. Eric Remstrom, Manager of Spiritual Care at St. John Vianney Center, a behavioral health hospital in Downingtown, Pennsylvania. Dr. Laudermith will address recent data and information related to mental health, and Dr. Remstrom will speak of a component of his work which relates to the integrated connections of body, mind, and spirit. I look forward to learning from their presentations. How we respond to mental health issues is one of the biggest challenges we face currently as a society, including on college campuses. Bringing the topic out into the open through fora like this one is one way to begin crafting a collective solution. So thank you once again for coming to Elms College today. I hope that you have an enjoyable day and that you find the forum informative.
Let us now welcome the Bishop of the Diocese of Springfield, the Most Reverend William D. Byrne, who will give opening remarks and our opening prayer.
Thank you, Celeste, and thank you, Dr. Dumais, for hosting us, for welcoming us. And again, I echo the words of thanks to you, Celeste, to Father Stelzer, and to Dr. McGreevy for the work, this important work that is being done here this morning. It is appropriate, first of all, that this forum be held actually at Our Lady of the Elms. First of all, Our Lady of the Elms is our gem here in the Diocese of Springfield. A wonderful Catholic institution, but raising up men and women who will be serving our local community, God willing, as mental health professionals, as medical professionals, as teachers, each a front line here, providing the services so deeply needed. But it's also appropriate that it's here because the church, and especially as voiced by our Holy Father, Pope Francis, is concerned with integral human development. The key word is not human or development, but integral human development. And our Holy Father has encouraged us to look at the human person, not just as a set of chemicals that are in one's brain or physical reactions, but as spiritual beings, as children of God, as those who have been created and loved beyond all comprehension. And so to those men and women here who are in the medical, heading towards a medical professional, this will be the gift that you bring in your work, to treat the whole person, not just the mind, not just the body, but the spirit, as Doctor will tell us. And so it is. I am sad I will not be able, because of my schedule, to join you here today, but I wanted to come and just pray with you. Thank you for coming, and tell you that this is a very important morning that you're spending. And I thank you for giving up, especially for those who should be on spring break. And so I'm going to begin with a prayer from St. Ignatius Loyola. And we can pray this with and for ourselves and for those also who deal with mental health issues. So we pray in the name of the Father, and of the Son, and of the Holy Spirit. Amen. O Christ Jesus, when all is darkness and we feel our weakness and our helplessness, give us a sense of your presence, your love, and your strength. Help us to have perfect trust in your protecting love and strengthening power, so that nothing may frighten or worry us. For living close to you, we shall see your hand, your purpose, and your will through all things. Amen. Thank you, and God bless.
Thank you, Bishop Byrne. Last year at our symposium, we had the great pleasure of having Senator John Velas with us, and unfortunately, he is unable to be with us today, but sends his best regards and notice of sadness that he cannot join us today.
Good morning. In addition to the welcome and thanks from Celeste, Dr. Dumais, and Bishop Byrne, let me extend a thank you to our planning committee for this year's symposium, Father Mark Stelzer, Sister Melinda Pellegrin, SSJ, who is somewhere, there she is in the back, as well as Deacon Dave Bergeron, so thank you again. Their help in planning this has been immeasurable. I'm pleased to introduce my friend, Dr. Ariel Laudermith. Ariel is a licensed clinical psychologist. She has worked for the Veteran Affairs Hospital System for 15 years. Her current position at the Central Western Massachusetts VA healthcare system is working within the Health Promotion Disease Prevention Program, specializing in health psychology roles. She serves as a health behavior coordinator and lead tobacco cessation clinician. What a mouthful. Okay. Specific duties include tobacco treatment, pre-surgical psychological evaluations, for example, bariatric, transplant, gender confirming, and training staff in motivational interviewing. Dr. Laudermith also provides services within the VA's Whole Health Initiative, such as biofeedback for stress/hypertension and relaxation-based stress reduction treatment. Dr. Laudermith earned her MA in Forensic Psychology from CUNY John Jay and her PhD in Clinical Psychology with a specialization in disaster mental health from the University of South Dakota. Please join me in welcoming Dr. Ariel Laudermith.
Good morning, everyone. Thank you, Dr. McGravy, and thank you for having me today. Let me just get situated. Can you all hear me okay? All right, great. So this morning I'm going to take us through a lot of data at first. I'm going to go through kind of what are we seeing with mental health, including substance use and suicide. What have we seen pre-COVID? What are we seeing now? I'm going to break it into young adults, under 18, and the general population. I'm also going to do a highlight on social connection, and then finally, I'm going to bring us through some interventions. How do we meet this increased demand, mental health first aid, and I'm gonna go through a whole health example. So let's start just from a little bit of knowledge on general mental health. So by the age of 25 years old, 75% of those who will have a mental health disorder have had their first onset. So 1 in 5 or US adults experience mental health. 1 in 20 US adults experience serious mental illness. And 17% of youth experience a mental health disorder. So I'm gonna get us at a baseline. What was happening in 2019, right? So anxiety, about 8% of US adults reporting symptoms, and depression, about 7% of US adults reporting symptoms of depression. So anxiety and depression are the top mental health illnesses that we will see. Why would COVID affect mental health as we start this talk? I think a lot of us have hypotheses, right? A lot of us can kind of assume why. Here's from the research what we're seeing, and I think all of us can relate to these things. Overwhelming fears and worries about COVID, maybe due to health issues. Misinformation from the media, that was a big thing. I think we can all remember that in 2020, 2021, all the information out there. There was also financial strain, unemployment, economic uncertainty, weakened social support, which we'll talk about, increased interpersonal conflict. What a divisive time that was in 2020, 2021, still now. But thinking about all the different interpersonal conflicts that people had. Domestic violence was on the rise because now people were stuck home more and weren't able to get support or help. College students at home without that peer support. Again, excessive information about COVID was not good for anybody. So continuing, this was really a new lonely for everybody. The isolation, the loss of moments, rituals. Who was supposed to get married during this time, right? Who had to have funerals in a different way during this time? Relationships changed. So even though this was a collective experience, as we're going to continue to talk today, we're going to realize it impacted certain populations differently. And we can think back to that time. Frontline workers were having a completely different experience than those who could work from home. Parents managing their own work and their children's online school, completely different than someone who is single and young and struggling with their own issues about not being able to interact with people in person. And those at greater severe risk of COVID faced their own unique challenges, like those who were in nursing homes at the time. Before I dive into the research, I do want to talk about what was happening with research during the pandemic. Has anybody kind of heard of this like pandemic speed of research that was happening? I see some nods. So during 2020 and 2021, what was happening was instead of going through a peer review process, that what usually happens with research, things were being pushed out quicker. And that's a great thing for many reasons, because then you can share research and data in real time across the world. Okay, what are we seeing from this research project? What are we seeing from here? But some of the cons were that we heard a lot of information that might have instilled hope in unproven treatments, and we saw a lot of misinformation. I was giving a talk in 2021 in tobacco, and I remember the headline at the time was, hey, smoking can actually be a barrier and help you if you get COVID. And I was like, oh no. And I had veterans asking me about this, and I had to kind of bring up this slide and be like, research is happening a little bit different, and we need to be careful about what's being spread. So I bring that up here because I'm going to talk about that a little bit, about what can we believe, what is happening in the research land. This graph is a little complicated, so my family has told me, but I wanted to bring it up because to really see also what we're seeing is with the blue line, so you can kind of see the dark blue line up there, this is an example with depression. So what data was being gathered during COVID? So the dark blue line is all the data points that there was tons of people looking at depression in COVID. You can see in March 2020, people were, okay, we need to research this. What's happening with depression? And that dark blue line goes down, as you can see. And the other line, the light blue line, is when the publications were coming out. When I looked in the literature to see, hey, what are we seeing with trends in depression with COVID, the data stopped. People kind of stopped looking into it. Around 2021, that's when the last kind of research papers were coming out with how is depression affecting mental health. And this could be for two reasons. Maybe there's a lower kind of desire to look into it now, kind of seeing the mental health trends and how they continue. And also, maybe the delay is back. Now we have the peer review process kicking back in, and it's 2024, and I can only find reviews that are really looking at 2021 data. We might have to wait a little bit long to really see how things are shaking out. So I just also want to say that the data on mental health and COVID has decreased, and I think it needs to continue. So let's start by looking at a highlight on the college age population in mental health. I think that you all know this and can relate to this, that mental health problems during college are predictive of lower academic success. Depression is associated with increase in that dropout. Mental health conditions in college can negatively affect quality of life, decrease physical health, and well-being. Pre-COVID, it's really important to understand the context that mental health symptoms and needs were increasing in the college population. Actually, they've been increasing for decades. That we've seen a dramatic increase in the demand for mental health services on college campuses. For example, in the 1980s, maybe 1 in 10 students could be characterized as needing, wanting, or using some form of mental health treatment, where in 2018, again pre-COVID, 1 in 3 students really met criteria for clinically significant mental health. So we have been seeing this increase. Just to kind of reiterate this is from 2008 to 2017. So the orange is 2017 to really see that difference. So you can see the bar graph and the first one really experiencing overwhelming anxiety, quite the increase over that 10-year period. Same with depression. Here we see very lonely, the percentage increase, as well as considering suicide in the 10-year span, the orange bar graph really showing the increase over that decade. Here's the trend from 2009 to 2015. The question was, within the last 12 months, have you been diagnosed or treated by a professional of any of the following? You can see around 2013, the anxiety, depression, and panic attack really went up. We had a large increase then. So there has been this dramatic increase in mental health needs in the college population. This all brings up the question that I'm going to have throughout this talk, is whether mental health of college students has actually been deteriorating, or it only appears this way because we have been trying to get college students and young adults and adults to seek treatment. We have been putting so much effort in decades to that, hey, how can we increase help-seeking behaviors? Has that been successful? So what are we seeing? A shift in attitudes? Are people more open to report symptoms? In the past, we didn't talk about mental health as much. I have my elementary age school children talking to me about their big feelings and the mindfulness they did in class today. We did not have that in the 1980s. So things have really changed with stigma and attitudes. But also there's data to show out there that maybe there is that worsening mental health. Are the actual increases happening? And there seems to be especially a generational with younger adults, adolescents, and children really emerging since the 2000s. Some people are saying, is it digital media? Is it increased academic pressure? Is it the chaos in the world that's led to all of this? Right? The racism, gun violence, climate change, all of these are possibilities. I'm not here to solve this question. It's important to understand that we need more mental health care, and that it could be a combination of both is happening, right? Let's look at what happened post-COVID. So we could see from 2013 in the college, I will say in the college age student, what I'm about to present, it's pretty clear that there was an increase in mental health needs through COVID, right? So from 2013 to 2021, we saw 135% increase in positive screens for depression, 110% increase for anxiety. There's a data set every year that comes out for college-age students. It's called Healthy Minds. And the most recent that I can get, even though it's 2024, is the 2020-2021 data. And over 60% of students met criteria for one or more mental health problems. That's a 50% increase from 2013. This data also showed that mental health really worsened across all racial and ethnic groups. There was decreased levels of flourishing, increased prevalence of depression, anxiety, eating disorder, and suicidal ideation over time. It's important to those see that the most significantly impacted students were those among racial and ethnic minority students, especially American Indian and Alaska Native students. They experienced the largest decrease in flourishing and the largest increase in depression. So among students meeting criteria for one or more mental health problems, there was a 24% increase for past treatment. So that's good, so people are getting treatment, right? We see that, okay, there's been an increase not only in mental health symptoms, but also in people seeking out treatment. I wanna point out some racial disparities that was in this report. So even though Arab American students experienced a 22% increase in meeting criteria for one or more mental health problems, they had an 18% decrease in actual getting treatment for this. Same thing happened with 45% among multiracial students. They had an increase in that by 45%, but their past year treatment only increased by 9%. So those ethnic minorities are not getting the treatment that maybe other students are getting. I'm gonna come back to college in a little bit, but let's look at younger children. There's been a lot of kind of debate in the literature about whether the mental health of children and adolescents has been impacted by the disruptions and restrictions of COVID-19. Spoiler, this data is also pretty clear that children and adolescents have been impacted greatly. So here are just two studies to really point it out, because I'm only going to present these two studies because it is clear in the literature here. That pre-COVID, with anxiety with people under 18 at the first year of the pandemic, 11% to 20% during the first year of the pandemic. Same with depressive symptoms, 12% to 25% during the first year of the pandemic. So 1 in 4 youth globally experience clinically elevated depression symptoms, more in the female side, right? So that's 25%. And then about 20% are experiencing clinically elevated anxiety symptoms. So increased in depression symptoms, particularly among females, we're gonna start to see patterns here. Females and this actually was the one study that found with children and adolescents, this is a meta-analysis, right? So they looked at 53 studies and tried to weed out what are we seeing. And they actually found that those with relatively higher incomes had more disruption and more depression. One of the hypotheses for that is maybe they had more scheduled things that all of a sudden these kids were not doing, more involvement that they were no longer doing. And they found that there was slightly increase in anxiety in that 2023 meta-analysis, but clear that we're seeing adolescent issues. In the general adult population, this is where it's a little bit murky. I will say pre-COVID, the same thing was happening with that college-age population. We were finding that more people were seeking out mental health treatment. So this graph just shows, in the light bar graph, is the 2014 to 2015 who was getting prescribed medications for mental health. And you could see from 2004, the dark blue, to 2015, there was an increase in people getting mental health medications. This is all outpatient mental health treatment. I will note that psychotherapy during this time didn't have as big as an increase that medication did, but both increased during the time frame. So the general population was seeking out more mental health and was having more diagnoses. What happened during COVID? This is where it's a little bit murky. Again, is it because the research isn't as well done? Maybe in 2021, this is a review study of 137 studies. They found that rather than a mental health crisis at a population level, there's been a high level of resilience during COVID, and things really haven't changed. I'm gonna show data that kind of goes against that, and I'm pointing this out because it's important that even though this study found we're not seeing much change, they did find the subgroups, just like we're going to talk about, right? Female cohorts experience worsening of general mental health, anxiety, and depression. And that is consistent across the board, that females, members of society, really experienced a greater burden of the pandemic. But so the general population, I'm going to show some data, though, that really points to everybody kind of struggled with mental health, including this general population. So the green line is so this is from data from 2020 to 2021. It's a sample of 49 studies. And we could see the green line and the yellow line, the green line representing mild depression and the yellow line representing moderate depression. We can see that the lines have increased and they continue to increase through 2021. So there's other studies out there really pointing to, hey, there is a big impact happening. This is another graph I think points to an obvious impact that was happening. So the solid line is anxiety and the dotted line is depression. This is from April 2020 to November 2020. I don't know if some of us can put our minds back during that time. And when I see the waves of anxiety, I can actually think about what was happening that first July 2020. Things were really in flux. Nobody knew what was happening. They were debating, hey, should we open up everything again? Should we not? There was a great debate what was happening in policy land, and you can see the increase in anxiety that happened. This is 1 million adults. So we saw that there was an increase in anxiety and depression through this time. And this study really pointed to the rising mental health challenges are being endured largely by the young, right? And we saw that in the college age, 25 and less advantaged people of color, and women. And that's really the thread here. 2021 happened, and this is the thread again, that this is any mental health illness. Who is experiencing any mental health illness in 2021? Females, 27%. 18 to 25, 33% of the population was experiencing any mental health. And then minorities also were having the largest impact here. This is for treatment. I just want to show the data from 2019 in the blue, so pre-COVID to 2021 in the gray. We can once again see that the 18 to 44 range, kind of the younger side of things, they were having the greatest treatment needs or seeking out treatment better than other populations. This is split up into women and men, and we see once again women had a higher percentage point difference of kind of those seeking out mental health treatment or needing mental health treatment from 2019 to 2021. This graph breaks down by race, and I think it's interesting because everything increased. People were getting treatment everywhere except in the non-Hispanic Black, we saw a decrease. But the research would tell us it's not because they were experiencing less mental health needs. They just didn't get the mental health treatment at the same rate that other populations were. So when the World Health Organization, when we just look at the 2020 data, they kind of said, hey, the data's mixed, but we can see that younger age, female gender, and pre-existing health conditions were risk factors. This is just a quote to show that through all of this, people are saying, why is mental health needs increasing? Is it because, right, stigma is receding? Is it because now we have practical barriers to mental health visits? Now, all of a sudden, we can do telehealth all the time. In the beginning, mental health treatment was really stressed in the pandemic. People couldn't see their providers. It was a real mess. But then quickly people realized we can do telehealth. Insurance kind of said go for it. There was not as many barriers. And then telehealth became a huge barrier divider. It took away so much barriers by allowing telehealth. So is that why we're also seeing a mental health treatment increase? I'm going to switch to suicide. And I think here when we talk about drug overdose in a little bit and suicide, we can see that there was certainly a mental health crisis. And I think this is where the data really comes into play. So first, the beginning data, the 2020 data, they were actually, some studies were showing a rise in suicidal behavior. Some studies were showing suicidal ideation and suicide attempts, but not the rate of death were increasing. And some studies were showing no evidence at all. Even though these are published in 2021, 2023, and 2024, all the data is from the 2020 era, right? So that's important because I'm about to show data that's after that time, and that's when the picture becomes a little closer. And that's why it's important to pay attention when we're looking at studies. So I will say in 2020, the suicide rates were lower in 2020 than they were in 2018 and 2019. And that's why those research reports in the beginning were showing that, hey, we're not really sure if we're seeing an increase in suicide, because in 2020 there was a dip. So that's why in the first year of the pandemic, the World Health Organization was like, we're not really sure. Maybe suicide's increasing, we're not really sure. It does seem like suicidal ideation's increasing. Then 2021 happened. And what we see is suicidal thoughts among US adults, especially 18 to 25, skyrocketed in 2021. Same thing with the same pattern that we're seeing, females being higher suicidal ideation, and then minorities also having a higher suicidal ideation. This is the provisional data because everything is slow in research. But what happened was in the blue was 2021, when we had the highest number ever recorded in the United States for suicides. So in 2021, the highest number. What happened in 2022? It was 3% higher than the highest number in 2021. So we can see that it increased. Yes, dip in 2020, shot up in 2021 and 2022. In this graph, I do want to point out that if you look at the 24 and younger, you'll see in 2022 that younger people had a lower, their suicide rate did decrease from 2021 to 2022. So I just want to point that out. Even though there was an increase, those 24 or younger, there was a decrease. I want to mention 988. How many people know about 988? Yeah, so quite a few. So this was actually in the works pre-pandemic. It slogged through the government from, I think, 2019. And it was a long number, like 1-855-275-8500, like for mental health needs, the crisis line. And they were like, it's actually mind-boggling why it took so long to figure out that we should make this number a little bit easier, like 911. So they switched it to 988, hoping that more people would access it, remember it. And indeed, that's what they found. So in 2021, when they still had the 10-digit number, there was 3.6 million calls, chats, or texts. In just the first year of having 988, they saw 5 million calls, chats, and texts. And I think we could just imagine adolescents, especially in youth, college age, everybody's going to remember 988 as long as we're publicizing this, but it's a lot easier to remember and it will save lives. So even though they didn't know it in 2019 that they're going to need this desperately in 2022, 2023, it was started a few years ago. Now I want to highlight on substance abuse and COVID, and it sounds like last year there was a discussion on this, and I'm just going to highlight a couple of things that we're seeing. So the first year of the pandemic, alcohol sales jumped by nearly 3%, the largest increase in 50 years. Can everybody remember the headlines? I remember the headlines in 2020. Everybody's buying alcohol. The media just grabbed that up. About 25% of people drank more than usual to cope with stress. The sales of really hard liquor really accounted for a lot of this. What they have found with other disasters is that these spikes usually last about 5 or 6 years and then slowly return to usual levels. But COVID is not just, COVID is a long pandemic over years, and I don't really know if we have historical data for that. So this still needs to be looked at continuously. We saw in the 21 to 24-year-old range, I'm just going to point out that the alcohol increased by over 5 percentage points. Binge drinking did decline. Actually, across the board, binge drinking declined in 2020, but people were drinking more. So we know why people increased their alcohol, really to cope with maybe anxiety, depression they were feeling. Not only did alcohol increase, but we also saw the increase in all different kinds of drugs. So researchers really found that the number of positive drug screens for cocaine, heroin, fentanyl, all increased after COVID. This is the latest data on alcohol-related deaths during COVID pandemic, and we can see the skyrocketing number from 78,000 in 2019 to 108,000 for alcohol-related deaths. That's certainly quite an increase. And then this is kind of a shocking graph looking at the drug-involved overdose deaths. So you can see in 2019, we were at about 70,000 drug overdose deaths in the US, and then it skyrocketed 2020 to 91,000, 2021, 106,000, and for 2022, the provisional number is 109,000. So it continues to go up with drug overdoses. Substance use trends look different though for the younger population, so that under 18, and this is really interesting. So there's a study that comes out every year, it's called Monitoring the Future, and it really looks at drug and alcohol use among adolescents and young adults. So 2021 was actually the largest one-year decrease of illicit drugs since the survey had started in 1975. Again, we're talking about kids younger than 18. And that has held steady through 2023. And here are the graphs to really show that. So the trends were already decreasing with alcohol use. So this is 8th grade, 10th grade, and 12th grade, how much alcohol we're using. Now you could see there was already on decline before the pandemic, but look at those drops at the 2020 mark, right, for alcohol. Then we can see this also with the prevalence of any illicit drug, drops for all of this for the 18 and younger crowd. Right there. When we look at nicotine use, we can also see that there's been a decrease for people 18 and younger. Why is this happening? Here's some hypotheses that I found in the literature. Delaying the start of substance use among young people, even 1 year, can decrease substance use for the rest of their lives. So the younger than 18 crowd in 2020, they might have been stuck at home. They didn't really have access to those drugs and alcohol, perhaps. And they delayed their start of substance use. Now here's the important part. So that's interesting, but here's the important part. The overdose rate is dramatic. There's been a rise in overdose of teens between 2020 and 2021, which is still elevated. So again, fentanyl seems to be the biggest driver here. So while drug use is not becoming more common among the 18 and younger crowd, it's becoming more dangerous. We're having more people die from using drugs because of fentanyl, and there is an overdose problem. So it's so important to talk to 18 and younger about the dangerousness of drugs continuously because the landscape has really changed. So even though there's decreases, it's more dangerous than it ever has been. So all in the context to say that there's a shortage of mental health providers, which I know you all are aware of here. The United States does not have nearly enough mental health professionals to treat everyone who is suffering. So already more than 150 million people live in federally designated mental health professional shortage areas. I know that in the field of psychology, they have tried to manage this for years by having some psychologists will get prescribing privileges because there's not enough psychiatrists, so there's certain states that allow psychologists to prescribe after a lot of training. They've tried to manage this by also more telehealth even before COVID, but now we're really seeing that, hey, more people want mental health, there's more needs of mental health. We already know that there's a shortage. And within a few years, around 15,000 to 30,000 psychiatrists, there'll be a deficit of it, and psychologists, social workers, and others will be overextended as well. So I say that as like a little nugget when we move into interventions, because we really all need to be a part of the intervention for everything. So let's highlight social connection. The Surgeon General's report, our epidemic of loneliness and isolation, who's heard of this report that came out in May 2023? So the Surgeon General kind of put out this report on social isolation, and demonstrating how important it is to make social connection. It's so important for mental health, we'll discuss that. But social connection had been declining for decades prior to COVID-19, so it was already going downhill. The onset of the pandemic with its lockdowns and stay-at-home orders really just raised awareness about the critical and ongoing kind of public health concern that we're seeing with this reduced social connection. More people online, more people on their phones. Emerging data really suggests that people with close and positive family connections had different experiences during COVID than those that maybe don't have any connections. Actually, a survey in 2021 found that 1 in 4 individuals reported feeling less close to family members, but the same survey also found that 1 in 5 said they felt closer. So maybe a lot of you can relate to this, but perhaps the pandemic really exacerbated family dynamics, connections, or disconnection. But a lot of us were with our family more than we had been, and so the pandemic kind of exacerbated our relationships there. So the Surgeon General really wanted to point out how social connection influences our mental health and our physical health. So disconnection really fundamentally affects our mental health, physical, and societal effects. Loneliness and isolation increase the risk of individuals to develop mental health challenges in their lives. And lacking connection can increase the risk of premature death to levels comparable as if you were a smoker. That's how important social connection is. So we can see that there's 3 different processes how social connection affects health. So biology, our stress hormones, inflammation, those are all related to how your social connections are. In psychology, the idea of meaning and purpose is so important for resilience, right, and mental health, coping. And social connection affects that. It affects how people feel about their meaning and purpose and hopelessness. And then your social connections in the world also really relate to your health risk behaviors that you're engaging in. So are you smoking? Are you drinking more? Physical activity is all related to your social connection. In the Surgeon General's report, really looking at kind of the extent to which an individual is socially connected depends on these facets. So if we're trying to intervene and help somebody have social connection, we can look at these 3 different things in their lives. So we can look at, hey, what's the structure like in their life? That's the number and variety of relationships. What's their friend circle? How about the function of their social connection? So this is kind of the degree to which relationships serve various needs. Are they getting emotional support they need? Are they getting help in crises? And then we can also look at the quality of their social connection. So how are they satisfied in their relationships? We know that social contexts also play a role in help-seeking behavior. So right on college campuses or even in our general lives, we see that people seek help from non-mental health professionals a lot, right? Especially in the college age. People will seek help from non-professionals, peers. In that Healthy Minds college data that comes out every year, they found that people were receiving help 78% from a non-professional, 67% from friends, and 52% from family members. So having different types of social connections is really important because we know people are seeking out help from others rather than like a professional. People seek help everywhere. And then I just wanted to say this quote that this research, it was in 2010, this was a research study, and social isolation is arguably the strongest and most reliable predictor of suicidal ideation, attempts, lethal suicidal behavior among samples of all ages, nationality, and clinical severity. And we have seen this over and over again in the literature, how lethal suicide behavior can be related to all different types of social isolation, withdrawal, living alone, losing a spouse. We know that marriage, children, or friends, family, the greater the number, the decreased risk of suicidal behavior. That brings us to kind of what can schools and education departments do about this social connection? So talking about this openly on a campus and developing strategic plans for kind of that connectedness between students, building connection into health curricula, right? Partnerships with key community, group projects, having the class kind of do social things together, implement kind of socially based educational techniques, so cooperative learning, peer relationships, mentorship programs, creating a supportive school environment that kind of fosters belonging through classroom management, peer support groups. What can workplaces do? So I'm going to talk about whole health in the VA in a little bit on the veteran side, but we also have whole health for the employees. So a large part of whole health in the VA is to help with this social connection, to help with this part, with the well-being. So making social connection a strategic priority in workplace at all levels. This is things as simple as all employee barbecues that we have, or we have pumpkin carving competitions, we have holiday dress-up competitions, but making us feel more like a group. Training the resource and empowering leaders to really promote that connection. So we go out as a team, we go out to dinner, we go out to lunch, trying to make those social connections. Really creating a practice in a workplace that allows us to connect to one another as humans rather just than as skill sets, but really connecting on who we are as people. And putting into the consideration of flexible work hours and arrangements. This was a roller coaster ride in the VA. At first, many of us mental health providers were at home working and seeing patients. Then they wanted us all back in. And then they realized that mental health providers actually, a lot of veterans wanted to see us through telehealth. They realized that for our personal lives, a lot of people wanted to be working from home, trying to do the juggle of everything. So then the VA was like, okay, a couple of days at home, right? So it was a roller coaster ride, and you can see it was to try to help employees in the workplace. How can we help you function in your personal life and your professional life, where we're still kind of giving the veterans the care that they absolutely deserve? So workplaces can do a lot to help social connections. So I'm going to summarize all the data I've presented up to this point and then kind of move forward to talk about in my last slides, like what can we do to address this? So we have really found that more young adults, especially young adults, so 25 and younger, need, and can benefit from mental health services. Resources are limited for the traditional one-on-one therapy that we all think of. So what can we do to address this? I'll just have one slide on this, digital platforms. We should all be aware that they're increasing, right? There's therapy online. There's different platforms for this. This was actually a systematic review and meta-analysis, again, looking at a bunch of studies to see what are we seeing with this. And they found in college age, they looked at, so I should say that all these digital platforms were research-based, so cognitive behavioral therapy, dialectical behavioral therapy, mindfulness-based programs. So all really research and driven and evidence-based programs. And they found that those programs work. They work online for many people. Particularly in addressing symptoms of anxiety and depression and improving social functioning. So it can be straightforward, especially with the young population. It can be engaging. The research is really robust and encouraging. I'll just be, I'll have to say to be cautious. Be cautious about which platform we're suggesting for people, right? Be cautious which app we're suggesting for people. It should all be kind of evidence-based psychotherapy. What can campuses do? So really, the literature is pointing to thinking outside the box. So we're talking about how can we increase the well-being of the population? How can we increase the resilience of the population for when we have something that is thrown in our way, when there's a barrier? And campuses have started to really do more group therapy, more peer counseling. We do that in the VA more and more, peer counseling, telehealth as well. But better equipping faculty and staff to spot and support students in distress. How can everybody respond to a crisis? Incorporate a broader culture of wellness into their policies, systems, and day-to-day campus life. Really thinking holistically. Really taking a multifaceted approach to supporting students. And it's everybody's responsibility to kind of create a culture of well-being. So we're talking about workshops on stress and sleep and goal setting. There might be some students who are mourning the loss of a typical college experience because of the pandemic. Maybe they're facing adjustment issues or loneliness. These are good candidates for peer counseling. So that we also have, though, the traditional one-on-one counseling still, right? So with students with more acute concerns, depression, trauma, we can still have them meet with professionals. So they're multifaceted, different levels. This is an example of kind of also to think about equity in mental health framework. So I pointed out a lot of data that really showed that the diverse student population are struggling more with getting their mental health needs met. So really thinking about how can we support racial, ethnic minority students? How can we build trust through racial trauma-informed leadership? Taking a collaborative approach to promote mental health for racial and ethnic minority students. So the framework has been most effectively implemented when you're working across departmental units, right? When we're working with the Office of Diversity, when we're working with student affairs, but trying to consider how we can help. So this overall framework focuses on a system level change to promote mental health equity. This is in line with the anti-racist approach to mental health, really seeing how inequalities stem from systems rather than individuals. I'm going to give a couple examples of what's happening out there in the world to help well-being of students. So this is at Toronto Metropolitan University, and maybe you all have this here and you can let me know. This school, actually, they do a 10-week in-person workshop series for credit, where we're just focusing on the well-being of students. Lectures on gratitude, attention, healthy habits. What's this gonna do? It's gonna help people cope with different things that might come up for them with their own mental health. So all of the lectures are really informed by psychological research to set students up for success in studying relationships and campus life. So students could take credit for that. I really like this idea. This is talking about mental health first aid on college campuses, and they kind of found that every staff need guidance. Not everybody feels comfortable, what should I do in a crisis, right? So what they have figured out was we're gonna make folders. So this actually started in the University of California, I think it was 2012, when they started it. They called it the red folder. Harvard calls it the crimson folder. I have a picture of Penn State who also calls it the red folder. And basically it's a quick online source where people can go and see, hey, how can we recognize, respond, refer, and then give resources for people in crises. So in recognizing, you click on the folder and it's gonna automatically give you, hey, when observing a potential sign of someone in distress, pay particular attention to notable changes in the student's behavior, performance, mood, and appearance. Now, professors especially see their students a lot. It might be the professors, right? Other staff at the college that are gonna notice if somebody is in trouble. And so in this folder that they have, it gives examples kind of for the staff and professors to really see, hey, what are examples for mild, moderate, and severe distress signs? And then they tell them how to respond. How do you respond to students in distress? Again, it can feel really uncomfortable and unfamiliar, but it's really important to engage the student, relay your concerns, be mindful of the student's background, identity, culture, as well as your own. So in the folder, you'll find, hey, what can we do to respond? And it's a reminder for you, right, to take your time, to stay calm, use those active listening skills that we all have, and ask direct questions. Really educating everybody that asking somebody if they're having thoughts of suicide is not going to put the thought of suicide in somebody's head. It is important that we directly ask people if they're having thoughts of self-harm. In the folder, you're going to find responding tips. And I won't go through these, but I just think it was a great idea. I think the VA needs to have a folder, right, for non-mental health providers that really just don't know what we should do in a crisis. And then lastly, I'll just give Harvard's example of, okay, how can we refer? So identify what the student needs. If you need to react immediately, let's call 911. If it's clearly reckless, dangerous behavior, okay, maybe you just need to consult if the student shows the signs of stress, but you're not really sure how serious it is. And if you're pretty sure, hey, this is, no one's in kind of immediate safety risk, let's go ahead and refer them. And then in Harvard's and Penn State, all of these different places, they have the exact numbers that you can call 24 hours to get help for. So now I'm going to move on to, I talked about kind of college campuses, but I'm going to move on to what we do at the VA. So the VA is the largest healthcare system in the nation. So what we do, kind of looking at a holistic approach, because we know that well-being is so important for resilience through stuff like COVID-19, right, through a pandemic, through traumas. So I'm going to go through kind of our whole health approach. So you can, in the folders, you'll have the personal health inventory there, and the whole health approach is in there. If you want to look along when I'm talking about it, you are more than welcome to. So what is the whole health approach? We realized in the VA that instead of asking people, what's the matter with you, right? Your doctor might say that to you. Instead, we want to say to people, what matters the most to you? So doing a whole cultural shift that's really taken place over the last decade, but most importantly within the last 5 years, focusing on what is the most important thing for people, because we know that's going to increase their health and well-being. So we have me at the center, so starting with what matters the most for people, and then we have mindfulness awareness, which I'll talk about in a second, and then we have self-care. And the point of this is that we want to support people in growing in these 8 self-care modules. So you'll see there's moving the body, surroundings, personal development, food and drink, recharge, family, friends, coworkers, spirit and soul, and power of the mind. And each one of these areas we know is related to helping people with their physical health, mental health, general well-being. So we want to help people really focus on this. And then on the outer layer, we have professional care. So maybe also some professional care. So really helping people manage their own self-care needs, and then we have professional care on the outskirts. And then we have community, because community resources are so important. We understand that no single person can be responsible for everything, for the mental health and health care of a person. Not one person can do it. We really need to lean on everybody. So we have peers, other veterans who run different groups who are empowering and exploring with our veterans what matters the most to them. We have all staff, right? We have a lot of clergy on our staff really looking at also how can they help, and I'll highlight them in a second. And then we have to empower the person. What can you do yourself to help with your self-care? How can we empower them to recognize that the health is in their hands? Let's empower them. And then we have specialized treatment for those who need it. So mindfulness awareness. This is really an important part of resilience. It's an important part of any health, mental health and physical health. But learning to pay attention to our present moment experience allows us to make choices that are aligned with our intentions. It allows us to take a pause moment. So the mindful me is mindful about your body, mind, experience, and how what you're doing relates to everything about yourself. Many of you might have seen this. It's the classic mindful awareness. Is your mind full, or are you being mindful, right? So it's a way of being in the present moment on purpose without judgment. So we do a lot of classes on this. Not specialized, as a psychologist, I certainly run some mindful groups, but we have a lot of people running mindful groups. We have it infiltrated in every place in healthcare, and it's important because everybody can do mindfulness. We know that mindfulness helps decrease depression, anxiety, worry. We know it decreases pain, improves hypertension, improves immune function. We know it can help people kind of decrease their health risk behaviors and improve sleep. Since we're here today kind of talking about the pastoral response, I wanted to zero in on that spirit and soul self-care module. So researchers found that religion and spirituality may affect a range of healthcare issues and mental health issues. We know it can help people make meaning and connection, which is so important in resilience and well-being. We know it can build optimism, reduce depression and anxiety. We know that spirituality can help individuals manage problems like chronic pain, diabetes, arthritis. So we know how important spirituality is for people's mental health and physical health. So in this kind of zeroing in, we can see that people can work with an expert, so part of our clergy staff. We can talk to people about spirituality, about making a change, exploring their values and meaning, working on grief and kind of moral injury, forgiveness. So all of this really helps people have a sense of purpose and meaning, which can provide strength in difficult times such as a pandemic or any trauma or difficulties people are having through their lives. So this is kind of what we tell veterans when we're working with and what our chaplains do at the VA. So really putting the patient and family members first. So they're providing support to the family. They're helping with decision making. They're helping with support and to help work through tough questions. They're providing grief support. They're assisting with ethical concerns. They're helping with feelings of guilt and forgiveness, helping connect people or reconnect people with God and higher power. Our chaplains are on our inpatient and outpatient. They're helping with groups. They're helping with mindfulness groups. They're part of our whole health fairs, really integrated in because we know that spirituality can help people during times of need. Right, so providing spiritual care improves patient outcomes. We recognize that. Many clinicians are uncomfortable discussing spiritual issues with their patients or, responding to spiritual questions. Many clinicians don't have the time required to offer good spiritual care. So chaplains are really comfortable working in this area and are really important as a part of our whole health initiative and the whole VA system. And then I'm just going to tell you a little bit about the personal health inventory. It's a self-reflection tool that you all have. Anybody, so our chaplains, the psychologists, our primary care providers, our nurses, can work with a patient with this tool. We actually use it on the employee side as well. So we also encourage our employees to fill it out because we want them to increase their well-being as well. So the personal health inventory kind of first helps people look at their MAP. We love acronyms in the VA. So the mission, aspiration, and purpose. So really thinking about, those things for you. And the MAP is really what matters the most in your life. What are your priorities? What's your vision of your optimal life and health? It helps people think about in all of these different self-care areas, where am I now and where do I want to be? So with recharging, people could kind of go through where am I now and where do I want to be? This is going to help people really understand where the discrepancies are, where they have opportunities, maybe where they want to increase that. Maybe there are 3 and they want to be a 4. Or maybe there are 3 and they're perfectly fine there for right now, and they want to work into a different self-care area. So this helps people see, hey, where do I have opportunities? Where would I like to make a small shift? Again, moving towards that well-being. It helps you see your self-care strengths. It helps you look at, hey, what are you really proud of? What are you a 4 in? And you're like, hey, I'm doing pretty good in that area right now. And then my last topic is resilience, which really is everything that we've been talking about. What we want to help, what the college campuses want to do with their designs, what we want to do at the VA. Everything is about improving resilience so that we can bounce back. So resilience is the process and outcome of successfully adapting to difficult or challenging life experiences, especially through mental, emotional, and behavioral flexibility. So psychological research really demonstrates that the resources and skills associated with resilience can be cultivated. We can teach people. We can help people become more resilient. There's protective factors that really play an important role in helping inoculate individuals against distress. We can help them learn coping skills like mindfulness. Fostering resilience is central to the whole health response in a number of ways. I won't go through this in detail, but really that we know that being clear on what you need and value is important to resilience, right? Knowing what's really important to you. Mindfulness is really important to resilience because you can stop yourself, right? You can stop yourself from going down a different path. If you're feeling anxiety or you're having thoughts of depression, you can have mindfulness to really be like, okay, let me center myself in a moment. Let me take a pause. And then taking care of yourself is so important to resilience. And then also receiving support at local and other organizational levels. So how do we kind of stay focused on our mission, aspiration, and purpose when we have setbacks? So 2 of the common ways to increase resilience are kind of offering self-compassion and gratitude practices. So self-compassion is at the heart of empowerment, learning, and inner strength. And gratitude really helps people feel more positive emotions, relish the good experiences. I want to make it clear that people with gratitude don't feel less negative emotions. That's not the point, people who are resilient. They just feel more positive emotions, those that are resilient. They're feeling more of the positive emotions. What does self-compassion look like? A lack of self-compassion, I think we can all relate to this. Like those thoughts of like, how could I have been so stupid? How could I have done that? Right? That's going to send us down a path of feeling of shame, demoralization, giving up. I know I had a lot of these thoughts in the beginning of COVID. My managing of children and work, it was a mess. And it was stressful, right? That lack of compassion. But what if we change that into compassion? What can I learn from this? Okay, I can try better. What can I do instead? It's going to help us keep going. It's going to help us have more hope and encouragement. And then I'll just point out a couple of different ways to increase gratitude, right? Thinking of things at the end of the day, reflect on your day and write down things that went well. There's gratitude rocks, selecting a rock and keeping it in your pocket or on your desk and taking time to really notice it, right? So really thinking about how we can weave gratitude into our practice. Because gratitude is something that's not going to work on the spot. If you went up to somebody who was in trouble or trauma and tried to say for them, hey, but look at all this. This is great stuff. You should be grateful for this. That's not going to work. That's not what we're talking about. We're talking about building and empowering people to start a gratitude practice so that when they are in distress, they can lean on their own emotions. They can lean on okay their own practice of gratitude. Appreciating yourself, thanking someone, letting yourself be happy, different types of gratitude practice that we can all intertwine into our day. So let me summarize everything that I discussed today. I went over the mental health trends pre-COVID and through COVID. We see that things are worsening and or more help-seeking behavior has been occurring. Either way, and it's probably both, more support is needed. COVID appears to have had a larger negative impact on the mental health of young people, females, and ethically diverse individuals. Number of suicides and drug overdoses have dramatically increased. Colleges and larger institutions need to think holistically about meeting mental health and general well-being needs so that we can build resilience at a population level. Involvement from everyone is essential. Thank you. Questions at the end, or? Now, or?
Questions now?
Yeah.
Unfortunately, despite my request, I don't have another microphone. So we do have some time for questions. If you can kind of speak loudly, and I'll ask if you can repeat the question so
Yes.
it's captured.
Okay.
So we have, you know, a good bit of time here if there are questions from the audience today. Don't be shy.
Yeah, I'm also, you know, maybe the data was surprising or right in line with what you're thinking. I'm curious about your thoughts as well. Oh, yep, we'll start here.
Well, thank you for, can everybody hear me? And thank you for this great presentation and you know, a lot of really fascinating data and interesting to see the, you know, what has been reported pre-COVID and what is, you know, the data that is gathering post-COVID. I'm particularly interested in what the data about young people.
Mm-hmm.
And as we've seen in, you know, a lot of increased diagnosed mental health
Yeah.
cases on students coming to campuses, and how, if at all, the literature and the research talk about the connection between that and social media and phone devices and those types of things. Anything that your research has encountered about, you know, what is happening in young people pre-post-COVID,
Yeah.
and any connection with
Social.
yeah.
Yeah, so I'll repeat it just to capture it a little bit, but talking about kind of young people and why the mental health diagnoses have increased, and talking about how that might relate to social media and the digital world. I think that in the research and literature, there's so much data out there right now to really showcase how social media and the digital age disrupts social connections, and leads to deterioration. And we see that all over the place, that social media is connected to more mental health problems. And I think that COVID just made that all worse. And that's why we need data to keep coming, right? It's to keep coming. I want to see the 2022, 2023, 2024, because it's our young population that has been affected the most from COVID. And especially because they went on their phones more and their devices and their social media more during that time. And social connection got even worse. So I do think that we're going to see more and more increase of this. And social media is absolutely a part of that equation. It's just, and it is newer at the same time. So this is going to be a wave that's going to be affecting, it already is affecting, and I think it's just going to get worse. So, thank you for that. We had a question back there?
Yeah, I had a question. You know, you mentioned the lack of professionals for the need, and it's only been exacerbated. Has the televisits and all that being available, and again, younger people are more comfortable, they use that form already, is that going to help the shortage? Because I don't know how fast you can get more professionals in the field, right?
Yeah.
How much is needed. Does this cut into that deficit?
Yeah, so the question is, how does kind of tele-mental health and tele-availability help with the deficit of mental health providers? Absolutely. So it is absolutely going to help telehealth, because not only can people see a professional, right, a psychologist, a social worker, but also we have so many groups through telehealth. We run a guided imagery group every Tuesday that people can hop into. We have Stress Less group that I run. That's a 4-session group through telehealth. So we're getting skills out to people who, maybe they don't need to see a professional on a one-to-one therapy, or maybe they are. And also we have these different types of groups and availability now through telehealth. So I do think that it's going to help with the deficit of mental health providers. The access to ruralness now that we have with telehealth is incredible. And it doesn't need to just be therapy, because it can be all of these other things that I just mentioned as well. So that is helping. And psychiatrists, it's easier access. We actually have a psychiatrist at the VA right now who's stationed in Florida, but because we're federal, our licenses can be anywhere. So we have a deficit of psychiatrists in this area, in central western Mass. And so we can have people living anywhere, and now our veterans have access to excellent psychiatry care through telehealth. Thank you. Any other thoughts or questions? Yeah.
Obviously religious practice, social practice helps with mental health and other issues, but we've seen for decades now a decline in religious activity, less people participating in any kind of religious or spiritual. Do you have any thoughts about how to kind of deal with both of those things at the same time? You start telling people they need to come to church because they'll feel better, which we try to do anyway. What do you think about that phenomenon?
Yeah, thank you for the question. So the question is, there's been a decline in people attending church services and religious services in general. And how can we help people support their spirituality, or what do we do with that? So this isn't my expertise area, but I will say what's on my mind. So I do think that we certainly in the VA, we talk about spirit and soul and spirituality in a very general practice, because we know it's so helpful. And our clergy at the VA are very, non-denominational, willing to see anybody. And that's what we really preach, kind of saying that this is helpful for anybody at any level. Religious, not religious, spirituality can look different to everybody. We talk a lot about meaning and purpose, and just finding meaning in your own life and being connected to something larger than us. And maybe that looks at earth and, being connected to the earth instead. But I will encourage everybody to explore that part, spirituality. And I think that the pastoral response can just be having open arms to anybody at any level where they are with religion. And I don't know if it's true, but it feels like religion has moved towards that a little bit, right? Having open arms for anybody, and giving the specialized skills that you all have in religion to everybody. So that's my thoughts on that. Thank you. Yeah.
I'm fascinated myself that studies like out of Duke Medical School and Vanderbilt and Emory, so not the seminaries at Duke, Vanderbilt, and Emory, but the medical schools, they have a lot of research about the effect of participation in the faith community that's transcendent, but also in person. So in other words, a transcendent faith community, Christian, Jewish, Islam, for example. But so something, as you mentioned earlier, something transcendent, something beyond us.
Yes.
So not like nothing against American Legion, but not an American Legion meeting. On the other hand, it's in person. So that there was people come, they see Millie, they see Ralph,
Yeah.
they see Frank or John, and there's a connectivity at that very community-based level. And so I think the diminishment in participation in person worship has disconnected a lot of people, especially as we move around. piece, especially with young people moving out of our area for jobs and life. So the seniors are left behind, but also the young people are in places really beginning from square one often. Sometimes it's important, but sometimes not.
Yeah. So I actually want to touch upon that. I think it's a really interesting, point to raise about this in person, right? And the disconnect that you might not have if you're online. And that's really important, because when I say that we have telehealth now, that doesn't mean that being in person isn't important. And it is to have that social connection. And I know in the beginning of the pandemic, I had so many veterans I was seeing that they go to AA, and all of a sudden, they couldn't go in person to their various AA groups that were at churches where they were. And what a drain of social connection for them. So absolutely, I think there is something, and a lot of people, especially maybe the older population, social connection comes from going to regular services. So the in-person is important. And I would be curious about the research looking at that, right? And is it different for now younger generations who are used to doing things online? Are they still feeling the same social connectedness that maybe older generations can't get from online? I think that would be really interesting, that information. Any other thoughts or questions? Well, thank you all for listening.
Okay, again, we'd like to welcome our guests from Gandhara, and we encourage you all to check out the resources and the materials they've brought with them today. We're going to take about a 10-minute break, so please grab some coffee. There's water, tea, some refreshments there, and we'll gather back for our second speaker in about 10 minutes. Thank you.